Hello and welcome everyone to this week's Croí Connects, where we aim to get you the answers to all your burning cardiovascular, health and lifestyle related queries. This week we're delighted to have Professor Francis Finucane joining us. Francis is a consultant endocrinologist and bariatric physician at Galway University Hospital and is also the Programme Director for Ireland's first Masters in Obesity at NUI Galway. Thank you for joining us, Francis. Let's get straight in, as we've lots of questions to cover across all aspects of obesity, from the causes to available treatment options, challenges when it comes to management, and of course, COVID-19. So to perhaps get started and set the scene, could you tell us what bariatric medicine is?
Good morning, Irene, and thanks very much for having me on to talk about bariatric medicine. I'm very pleased to be here. Bariatric medicine refers to the care of patients with severe and complicated obesity. So as we all know, obesity has become more common in the population, but we've also seen an increase in the numbers of individuals who are affected by very significant weight problems. So they might have a much higher weight than average, but also they would have the complications of overweight and obesity, such as type 2 diabetes, arthritis, sleep apnea, fatty liver disease, and the other cardiovascular risk factors we're all very aware of. And so there's been a growing need to develop care pathways for those patients. And these are often hospital-based, although not always. And effectively, what bariatric medicine refers to is the multidisciplinary care that these patients receive when they attend a hospital service or a specialist service. So that could include nursing care, psychological care. Obviously, dietitian care is very important for these patients. And also, they'll often need to see a doctor, be that a physician or a surgeon, because there's a wide range of therapies now that we can use for these patients.
So about a quarter of the Irish adult population are obese, and I suppose the next number of questions really reflects the challenges that people living with obesity have. So Sandra from Athlone says her whole family struggles with their weight, and she's wondering, is it genetic, as we do our best to try and lead a healthy lifestyle? So I think that the topic of genetics is very important here.
Absolutely, and Sandra's question is an excellent one, and it highlights some of the complexities that we face in trying to understand the nature of the obesity problem, if you like, and also how we're going to disentangle that problem and provide solutions, again, both for individuals and for society. And there's often this sort of debate and this dichotomy, if you like, between, oh, it's a lifestyle problem versus it's a genetic problem, and or indeed an environmental problem. And the truth is that all of these things interplay with each other to give rise to someone's risk of being overweight or obese.
Okay.
Yeah, so I mean, definitely genes play a critically important role. You know, this has been well studied and it is well understood. So you can examine the heritability of traits like body mass index, similar to other traits like blood pressure or height or skin color. You can do reliable studies that demonstrate to what extent genetics play a role. And for body mass index, we estimate that it's around about 70% determined by your parents. So it's an underlying biological determination of what your body mass index is. Of course, over time, your risk of having a high body mass index might change depending on the exposures that you have in the environment, such as unhealthy food, etc. So these are things that also play a role. But at any point in time, if you take, say, a classroom full of children and you examine whether, you know, the extent to which genes play a role in their weight, you will find that about 70% of the variation in the weight of those children in that classroom is accounted for by genetics, and about 30% is accounted for by other factors. Now, people often say, Irene, if I may just continue on for a moment in that regard, people often say, well, you know, the genes haven't changed over the last number of decades, and over the last 30 or 40 years is where we've seen the particularly dramatic rise in the prevalence of overweight and obesity. that is true. And I would say that the change over time in overweight and obesity within the population and within society has been driven by environmental factors, like the availability of unhealthy foods. But at any point in time, the variation in a population is largely genetically and biologically determined. And we need to recognize that problem, or we need to recognize that if we're going to deal with the problem effectively.
And following on from that, Francis, the next question is about set point weight. So, you know, do our bodies have a preset weight range that sometimes, you know, that's somewhat hardwired into our DNA? And is this something we can overcome, or how do we address this? And this was a question that came in from one of our Croí Connects participants, which is an obesity management program that we run here in the Heart and Stroke Centre.
Yeah, again, that's a really excellent question. So the set point theory refers to the fact really that individuals try to restrict the amount of that they take in. And when they try to lose weight through sort of self-directed modification, often you'll see a transient weight loss, and it may be very substantial, but over a period of time, there tends to be a pattern of weight regain. And we've seen this ourselves in our patients with severe and complicated obesity who've undergone very dramatic weight loss through meal replacement programs, where if you follow these patients up over time, then on average, there's a high likelihood that those individuals will actually regain much of the weight that they have lost. And that's not because they've had a lapse in moral integrity or a lapse in their motivation. Often people attribute abnormal eating behavior to some sort of psychological lesion, and often that is not.
So Francis, one of the questions that we've received in just relates to dieting. So I've been on lots of diets before and can lose weight in the short term, but always put it back on. Why is this?
Yeah, it's a common challenge that we hear from our patients, particularly coming to the bariatric clinic in the hospital, that they have been there and done that, so to speak, before, sometimes with very significantly restricted diets, with maybe, you know, 1,000 calories a day or that sort of level of calorie restriction. And often patients will find that they lose a great deal of weight in the short term with these diets, but that there's subsequently a sort of relentless weight regain. And that's related to the set point theory that we mentioned. And this is something that is very, very difficult to deal with in clinical practice through dietary modification alone. And the fact is that not all diets work exactly the same for every single patient coming through the door. And obesity is a complex problem. And there are likely to be different physiological drivers for one patient coming in than for another patient coming in. And we're beginning to realize now that some patients respond very well, say, to a calorie restricted diet, and that may be sustainable for a proportion of those people into the future, whereas other patients don't respond well to that. They have that weight regain from the sort of set point theory of going back to the previous level of weight that they had. And for those individuals, sometimes a sort of an alternative dietary pattern might work well. And there's growing scientific and clinical interest, again, in the in carbohydrate restriction. That's something we're seeing more and more discussed in the media, discussed in the scientific literature. And it's something we use occasionally in patients who are maybe struggling with feeling very hungry in the hours after eating food. And say, for example, people with insulin resistance or type 2 diabetes. And those patients can sometimes respond well to carbohydrate restriction. So that's one sort of example of a niche dietary intervention that we can use in patients who might struggle with that weight regain. But again, that does not work for every single patient coming through the door. And what I would say to the person who's asked that question, it's certainly something to consider discussing either with your GP or with a dietitian. We certainly have conversations with patients all of the time around what the next step is when dietary restriction may have worked in the short term but hasn't worked in the long term, especially when patients have problems related to their overweight and obesity, as I said, like diabetes and heart disease. So in those individuals, you can move to the next step, which is where that bariatric medicine role comes in more, where we might consider various different medications to help people change that set point and change their eating behavior, or indeed for some patients, an operation, a bariatric surgical operation, be that a sleeve gastrectomy or a bypass procedure, can be a very effective way of reducing the set point so that your dietary behavior changes, you lose a significant amount of weight, and then you keep it off.
That's great. And perhaps shortly we can discuss some of those treatment options, Francis. But I'm also interested to know about hormones and the role hormones play when it comes to affecting weight, and particularly people who suffer maybe with hypothyroidism or polycystic ovary syndrome. Could you tell us a little bit more about that?
Yeah, so certainly in individuals who are really struggling with significant weight gain, it's important for the medical team to exclude an underlying endocrine or hormonal cause for the excess weight. And indeed, many of the doctors around the world who are specialists in obesity care are from an endocrine hormone interest background, if you like. So, and it's true that the medical textbooks will tell you that, you know, too much cortisol or not enough thyroid hormone can be associated with overweight and obesity. But the truth of the matter is that it's extremely rare to encounter a patient with severe obesity, say in the bariatric clinic or in clinical practice in primary care, where the underlying cause of the problem is one of those traditional hormone problems that an endocrinologist would see. So while we check this, we rarely find it to be a cause of weight and obesity per se. And it's really important for patients to recognize that fact. You know, sometimes you might have very reassuring thyroid blood tests, for example, but occasionally patients are convinced that their thyroid is still the problem. And there's a whole sort of area of practice where people are maybe given thyroid hormone treatment, say on the internet and such, where it isn't necessarily indicated, certainly for weight problems. And I would just say one further thing. We encounter people all of the time with very significantly low levels of thyroid hormone. And even in those patients, weight gain doesn't tend to be a very big problem. So hormone problems are less relevant than most people believe when it comes to their weight trouble. You know, now that said, Irene, I would have to say that we may not fully understand yet the subtleties of some of the other hormones that we haven't traditionally thought of in terms of weight problems. So one interesting hormone is insulin, and insulin is a very important hormone in controlling your blood sugar levels. And when insulin doesn't work properly, it gives rise to diabetes. Okay, so that's a very common problem. We see an awful lot of diabetes in our clinics. What's interesting is the role of insulin in controlling your appetite and your hunger levels and how full you feel after a meal. Be that through modification of people's diets, their insulin levels can be brought down, and that might influence how they feel about food subsequently. So there might be a sort of a virtuous circle of dietary changes giving rise to lower insulin levels that might in turn give rise to an altered perception of food and hunger. So it's likely that some of the common hormones play subtle roles in our eating behavior, and that this ultimately gives rise to your risk of overweight and obesity.
Okay, so Francis, the next question has come in from John in Sligo, and this is one I think that's quite concerning. So John has obesity, and when he goes for medical appointments, he feels like the doctors are dismissing his symptoms and blaming his weight. How can I get them to take me seriously?
Yeah, John's question again raises a very important issue that's well described in medical research literature, and that is that there is this bias and stigmatization that people with overweight and obesity experience, not just within the healthcare context, but also, say, in educational institutions and, you know, and all walks of life, really. So I think it's really important to acknowledge that John's experience is a real problem. It does happen. And it's important not to just sort of sweep it under the carpet or dismiss it as an exception. I do think, though, that there is, a growing realization that we need to change our attitudes to patients affected by overweight and obesity. I think things are changing for patients. Healthcare professionals are understanding obesity better, and they're understanding better how to manage and treat the condition as well.
And I suppose in many ways, Francis, the new master's program that you're setting up at NUI Galway will go a long way, hopefully, to supporting some and addressing some of these issues.
Yes, certainly we would hope so, and that is one of the main aims we have of setting the program up. It's so heartening to see that level of interest from the university that they're willing to engage and invest in this program. It's also great to see the collaborative efforts across other organizations like the National Institute of Preventive Cardiology, Croí, of course, which is an integral part of the delivery of care for patients with severe and complicated obesity from the west of Ireland, as well as the work that Croí does at a population level. So it's great to see all these stakeholders coming together, and it's great to have the expertise again across psychological, nursing, surgical, and other domains. Dietitians, of course, are critically important in that. And it's wonderful to see the level of interest in the course from healthcare professionals. I guess to some extent, individuals who are seeking to engage with, lifelong learning around obesity, and people who want to do this course, they've already decided that they see this as more than just a sort of a lifestyle failure, if you like. We need to get it out to other stakeholders as well. And in particular, our political leaders, our senior healthcare managers need to take this problem much more seriously, dare I say it. And it's great to see some investment so far in services nationally, but I think that needs to be developed significantly more as more and more people are affected.
Yeah. And of course, I think particularly during COVID and now that, we're coming out the other end, it's really important that the message that we're all trying to promote is really about, going back to your GP, following up. People who are living with obesity have lots of other, conditions as well. And it's really important that people take the time to go to the GP and that the GP does take them seriously. So, and it is about how we view this as a chronic disease. Now, we've heard a lot about the stigma in relation to obesity, in relation to COVID-19, and we've heard about the ICU admissions and all the rest of it. But could you tell us a little bit, Francis, about why people who are living with obesity are a high risk group, and for them, is there any advice that you could give them at this moment in time?
Yes, again, it's a brand new problem really in clinical research terms, the COVID-19 epidemic, and certainly the initial information we were getting from countries like Italy and the States and China was that individuals with severe and complicated obesity, say with a body mass index over 35 or over 2 diabetes, for example, were much more likely to need intensive care unit admission. And if they were admitted to hospital, they had a higher chance of dying than individuals with a normal body weight. Whether that risk applies to, the majority of Irish adults who have overweight or obesity remains to be determined. But it seems prudent and sensible to say at the moment that if you have a weight problem, you're probably at higher risk from this COVID-19 crisis. And the higher your weight and the greater the level of excess weight that you carry, the higher your risk from COVID-19. But other factors come into play as well, such as age in particular is a very important consideration, whether or not you have diabetes or blood pressure. These things are also important to consider. So when a doctor or a clinical team is making an assessment about somebody's risk from COVID-19 when they present to hospital, certainly weight may come into the consideration a little bit, but other factors are much more important. Let's talk about the clearly defined high-risk group, and that's people, say, attending bariatric services and people with BMI over 35. I think for those individuals, I would recommend, and I think the government have put out clear guidelines on this, and I agree entirely with those guidelines. They're very carefully considered, measured, authoritative from Donald O'Shea and the National Clinical Programme for Obesity. They put together a very, very good document stating that individuals with very high BMI do need to be much more careful about isolating, in the same way that we have advised people over the age of 70 to essentially cocoon during the crisis. So obviously those restrictions have been significantly reduced again at this moment in time, early July, but you need to pay attention to government advice about the level of isolation that you need to deploy in reducing your risk. And if you have a body mass index over 35, you're definitely at high risk. For the rest of us, I think the challenge for everybody, not just people who have a high body mass index during the COVID crisis, has been maintaining mental health, ensuring that you're getting enough physical activity, ensuring that your alcohol consumption hasn't gone to unhealthy levels, ensuring that you're managing stress and this new challenge that we've all faced. And also dietary patterns. We need to maybe concentrate more on eating healthily when there's a problem like this distracting us from those from leading as healthy a lifestyle as possible. And I think that healthy lifestyle applies now more than ever with the current COVID crisis.
And Francis, have your services resumed in Galway University Hospital? So are surgeries happening at the moment? Are you seeing patients?
Yeah, so the short answer to that is some of the services have kept going, but we've had to adapt to the challenges that all healthcare facilities face. So we're currently providing clinic consultations by telephone. Now we're hoping to develop with the HSE video consultations, which will make that a little bit easier. And obviously, as soon as possible, we'll resume normal face-to-face consultations within the hospital, particularly for new patients. But I think for many return patients who've traveled from all over the country to attend our service in Galway, it's a blessing in disguise, or it's a silver lining to the cloud of COVID-19 that they are now able to communicate in a much more efficient way than driving to Galway and taking a day off work. So that is changing how we're doing things. And I know, for example, at Croí, the delivery of the CLAN program is now entirely virtual. And I've just been amazed by the progress you have made in delivering that care to patients using remote platforms. And I think our patients are very grateful to you for that. So we've had to adapt to some extent. Obviously, it's had a huge impact on patients' access to bariatric surgery. And that, I would say, Irene, is probably the biggest challenge we face in the west of Ireland in the coming months. And that is restoring that bariatric surgical activity that we had worked so hard to develop over the last decade.
Thanks, Francis. And of course, with the programs that we deliver here in collaboration with yourself, it is the silver lining. COVID-19 has made us think very differently about how we work. And I'm delighted to say that we now have 2 CLAN programs as of this morning up and running, and we have over 50 patients engaging in a virtual online program. So that's, I think, really positive and really exciting that people are getting the support that they need at this time. Francis, just in terms of your service, because I know a lot of people were wondering, how do they access the bariatric medicine service? Is it referral by GP, and is there specific criteria?
Well, yes, that's a great question. So it's important to state that we have, a very active bariatric service within the hospital. We see over 500 new patients per year. Our waiting list, waiting times are up to 12 months for some patients, and we're working really hard to get those waiting times down. But for individuals who need urgent assessment, we'll often be able to fit them into clinic within 3 to 6 weeks. So I would say to patients who are watching this and considering whether or not they'd like to access the service, key thing is speak with your GP and explain that you feel that you would benefit from specialist intervention with your weight problem. And I think anybody who states that to their GP ought to be referred straight into the service. You don't need to jump through any sort of hoops first, to be honest, to show that you're sort of motivated or anything like that. That just is an area of clinical practice that has just disappeared now. So if you're somebody who feels they need help with their weight, then we are happy to see you in our clinic. Now, we do have referral criteria in terms of what the body mass index threshold should be, and it should ideally be above 35 for patients being referred to the clinic. But to be honest, often patients have complications related to overweight and obesity and have lower body mass indexes. And we would be happy to see those patients if they're keen to be assessed and if their doctor feels that it's an appropriate referral.
Francis, we're drawing to the end of the session today, and I just wanted to ask you, because a few questions came in relation to treatment options for obesity, and I know you've referred to some of these earlier in the session, but just in relation to surgery, there are different types of surgery. Which is the one that's been recommended at the moment? Because this is a question from John in Tipperary, who's currently coming into your clinic for assessment in the coming weeks.
Yeah, so as I mentioned, many of the domains of care that we provide in Galway for patients experiencing complicated obesity are really well established. The waiting times have come right down to them, such as the Croí Connects program. Our access to drug therapy is excellent. But surgery is something, again, we've got excellent surgical expertise in the hospital. And one of the very first bariatric centres in the country was established by Professor McEnena back about 15 years ago. So we have this outstanding expertise, but the problem is we don't have capacity within the hospital at the moment because of the shortage of surgical beds. So our challenge is to get patients into those beds and invest in those services so that those beds are protected for these patients. So that's been a real problem over the last 2 or 3 years. To answer the question of the patient, though, there are different types of surgery, certainly. Some surgeries are restrictive. What they do is they reduce the size of the stomach so that when people consume a meal, they feel fuller quicker after eating. But more importantly, that operation changes how the stomach talks to the brain. And so the brain feels differently about food. It doesn't change, again, someone's motivation. It doesn't change their intelligence or understanding of healthy eating. And it doesn't change their their moral integrity. Rather, it changes their physiology and it changes that set point, and it works very, very well for almost all patients who have it. There are some risks associated with surgery, but those risks are small and are about the same as the risks associated with having, say, a hysterectomy or a hip replacement. So the risks are relatively small. People tend to be in and out of hospital within 48 hours when they have this operation. But it is a life-changing operation, and people need to be committed to that lifelong change. There are other types of surgery. For example, bypass surgeries can be done, and that applies to specific types of dietary patterns that patients might have before they have the operation. The type of operation is less important, we think, than access to it. So there are different operations to suit different patients. The big problem we face at the moment in the west of Ireland and nationally is access to that operation and access to those expert surgeons that we've appointed in our hospitals. So I hope that with the new National Clinical Programme for Obesity, that's going to change over the next months and years.
Absolutely, Francis. And, I think given, we talk about obesity now, we're talking about it as a disease. And, when we look at it, when we look at cardiovascular disease and we look at, people who have blood pressure, we support them in terms of we prescribe the right drugs for them, and people with, disease in their arteries, we provide them with the right medical interventions. So in many ways, obesity shouldn't be any different. And I think what I'm hearing today, that it's really very much about an individualized approach. It's a complex disease. There's multiple causes. It's not as simple as just saying it's a lifestyle choice. And we need to look at it from all of the multiple perspectives here. Francis, as we near the end, I suppose I'd like to give the last word to yourself, and if there are any key messages that you would like to finish up and communicate to the public today, that would be great.
Yeah, thanks again, Iron, for the opportunity to do that. I suppose two key things I would say. One, to patients or potential patients who are concerned about the impact that weight is having on their health. if you feel you need the help, we have the capability of providing you with the care that you need. So you need to encourage your GP to refer you to our service. We would be delighted to see you. The second thing I would say is that taking a broader perspective on this, while it's important that we provide care to the individuals for whom the obesity time bomb has already gone off, if you like, we also need to address the societal drivers of excess body weight. So we need to have, wider cycle lanes, better opportunities for kids to be more active. We need to have better access to less processed, healthier foods, and maybe more restrictive access to unhealthy, highly processed and ultra-processed foods. So these are changes that are increasingly recognized as being really important if we're going to do anything about the numbers of individuals within the population affected by this problem over the next decades.
Great, thank you, Francis. So it's really what we need is an all of government, all of society and individuals, all of us working together collectively to address this challenge, because obesity is a pandemic. We've been in the COVID pandemic for the last number of weeks, but actually the obesity pandemic has been going on for far longer. So we really do need to be looking at this and putting our energies into this in terms of moving forward. So thank you for joining us on Croí Connects today, and thank you to all our viewers for taking the time to submit your questions and for watching. Croí Connects returns in 2 weeks' time again, and we're delighted to have Dr. Jenny Jones join us to talk about physical activity and how we can move more and avoid sitting. Jenny is a physiotherapist by background, and she's also Director of Education and Training at the National Institute for Prevention and Cardiovascular Health, and she's also Senior Lecturer at the School of Medicine at NUI Galway. So do get your questions in now. Visit croí.ie, or you can call us on 091 544 310. And don't forget to stay tuned to our website for lots of great resources, and please follow us on social media as well. Thank you for watching.